Tim Malloy with the Civic Association and Palm Beach TV, and this is a program in conjunction with the town of Palm Beach. It's a continuation of our series entitled Your Town, Your Safety, Your Well-Being. Today we confront likely the most urgent matter this town has ever faced. In the last week, COVID-19 cases have surged in Palm Beach. It's not at all surprising the town population is swelling to and possibly beyond peak season levels right now. So in this program, we go to our local experts with a clear-eyed and quite sobering view of where we are with COVID-19, where we may be going with infections, and ultimately, hopefully, soon a vaccine. We urge you to watch it through to the end. Here's Wendy Rutledge.
Dr. Alina Alonso has served as the Florida Department of Health Palm Beach County Director since 1989. As director, Dr. Alonso oversees the operations of one of the largest county health departments in the state. She is the medical voice of the County of Palm Beach, where matters of public health are concerned. Dr. Alonso has provided ongoing guidance to the citizens and decision makers of Palm Beach County on the COVID-19 public health crisis. Maggie Zeidman brings us an insightful interview with this public health leader.
Thank you for being with us, because I know how busy you are, and we really appreciate it. Our town has looked to you all along for the last 9 months, and here we are today sitting here with you, having you help us with this next phase that we're going into. So I just want to thank you for that. Your job is huge. You serve the healthcare needs of a widely divergent population, from maternal child health, the homeless, schools, prisons, the elderly, and the town of Palm Beach. The public relies on the department, the director of the Department of Health, the doctor, to tell us what to do. And doctors are doctors always the head of the departments of health?
No, they're not. The larger counties definitely have physicians, but some of the smaller counties have administrators, and then they use just a medical director to do their clinical work. But we've been very fortunate. We've always had a doctor. We've had only 4 directors, actually. I'm the 4th director. So in all these years, since the 1950s.
You tell us what to do. Dr. Fauci tells us what to do. Dr. Redfield tells us what to do. Dr. Birx tells us what to do, but we don't do it. And therein lies the problem, So tell us where we are today, here in the county, here in the state. We'll start with the state, macro, the state, the county, and then our little town.
Well, it's very important that we even look at it globally, right? Because this is a global problem. Every single country is involved in this, not just us. And so the United States right now is in a 3rd peak, in addition to being the 2nd wave. Early on in the pandemic, we talked about that there would be a 2nd wave in the winter. We were hoping that, it'd be all over in a few months. Well, obviously it's not, because viruses don't work the way we want them to work. They work the way they want to work. And this virus is following that same pattern. So we're in the 2nd wave on top of a 3rd peak. Which right now there's over 100,000 cases per day coming into the United States, and so Florida is doing better than some of the other states, and Palm Beach County is doing much better than Miami. We have a very large population of the whole state, and so we're large counties with metropolitan areas over 1 million people. And so we have more of a burden than the rest of the state, right? It's natural because we have large concentrated communities with transportation and people moving. And also we receive a lot of that population coming from the north, especially now in our winter. We know we have a lot of tourists that will be coming, and lots of people that come here regularly this season. So because of that, we are expecting that this 2nd wave is definitely going to be very, very serious now in December and January. We had a little reprieve with our numbers going down, our positivity going down. And that, I think, had a lot to do with all the people that traveled. Over 1 million people traveled over this holiday, even though the CDC was asking people not to travel. And so we had a little bit of a reprieve because a lot of people got tested and they were negative. So that large number of activity in testing reduced that positivity. But now, as we see, our numbers are going back up. Yesterday we had 9.87. And so we're going to see this number fluctuating with more people getting tested. The CDC also asked anybody who had traveled, that 1 million people that traveled, to get tested, because the fact that they've traveled, they've come in contact with the virus. So we definitely encourage people to get tested now that they've come back, to make sure, because there's so many people that are asymptomatic with this virus. That's another very important thing. So for that reason, our expectation going into this is that we're going to see a lot more positivity and a lot more of the virus.
So you get a dinner party together and everybody looks okay. You look okay. You feel okay. They look and feel okay. But you're sitting next to each other and you have masks off because you're having dinner with one another. And the next thing you know, about 5 days later, someone has symptoms. And then somebody else has symptoms. And so we've had a few occurrences of this happen here in the town.
You have to assume that every single person that's next to you is positive. If you keep that notion in your head, you can protect yourself better. You cannot assume that you're close. We call it our close bubble, right? We have a certain group of people that we know, perhaps our family members, and we feel safe with them because we know them. But the moment they go out to the street, or they go to work, or they go to play, or they go to the office, they're coming in contact with other people. So when they come home, they're no longer that safe bubble anymore. So you have to keep in mind that everybody that you get next to, you have to assume that they have the virus. Then you can protect yourself, because then you're going to keep your mask on, and you're going to stay. If you don't have your mask on, then you need to stay away from them. So how do you do that when you go to a dinner party? And I've done it, right? So I've gone to my friend's house, my little bubble. I have 2 bubbles that I circulate in. And I go to the first bubble and everybody's doing fine. So we sit down for dinner. If we sit down to dinner next to each other, the way we normally sit in a table, we're taking a big chance. Now, everything with the virus is a matter of mitigating, right? We can't eliminate the virus, and we all take chances that we're willing to take. So when my son came home from Tallahassee, I hugged him, and he got very upset with me because I hugged him. He says, "You can't hug me." I said, "But I have to hug you." Mm-hmm. So there are some things that we're willing to take a chance on, just like we drive on 95, and I needed to hug him, but he was correct. I should not have hugged him. I should have waited until he was here for a few days so that I knew he was safe. The other situation that occurs is that we feel, well, it's no big deal, right? You're just going to be sick for a few days. So if I hug him, the worst that can happen is I'm sick for a few days. Well, it's a little more complicated than that, because the fact that I'm going to work means I'm going to then expose other people to my illness, because I'm not going to know that I have it, because chances are I'm not going to have any symptoms. So it's not just the chance that I'm taking, it's the chance that we're exposing everybody else to. So at work, you can wipe out a whole department. If you only have 4 or 5 people at work, that whole department may be out because one person, I call it messing up, wasn't cautious enough to take that precaution. And then you have 4 or 5 people out at work. The other problem then is consequences to this virus. We cannot take this seriously enough. We are finding more and more complications. It's not just getting the flu. You may recover and just get the flu, but there may be long-term consequences. People have been hospitalized, and healthy adults that run, that do exercises, that are perfectly fit, have had a very hard time coming off of this thing. So you're taking a much greater chance than you think.
So Christmas is going to be difficult for us.
We are actually make civil sacrifices, each one of us, when we decide not to take that trip or not do that for this year. And somebody said it, I think, very well. They said, we're doing this year. We're not seeing you this year so that we can keep seeing you for the years to come. I think that anybody who has to live with that maybe they caused somebody's death is very, very hard to do. We do want to keep the schools open. The problems where I'm seeing are the clubhouses, the private clubs, the nightclubs, the bars. All you have to do is drive down Clematis or drive down Atlantic Avenue, and you see where the problem is. It is not, in the classroom. It's at these places where you're gathering without the masks, large crowds.
Let's talk a little bit about, you brought up the positivity rate. Tell us about that. Sometimes I'm asked, what's the equation?
We were talking about the total positivity and then the daily positivity. The important one is the daily positivity. That is the number of tests that we do today, and the number of positive tests that we have on that day. So that's the daily positivity. So the number of positive tests for today divided by the total number of tests that we do. And there's two ways to calculate that. They're both correct. The CDC came out with a statement in terms of a little differences. The different counties, different states are doing it a little bit different. They're both correct. The important thing is to keep the same equation the same throughout the event. And that's what we've done. So here in Palm Beach County, we take total number of positive people that we have today divided by the total people that were tested. That tells us how much viral load is in the community on that particular day. That's the daily positivity, and that's the one that we saw all the way down to 2 back in October, I believe you mentioned. Yeah. And now it's up to, yesterday was 9.87. We want to keep that number below 5. Why is it 5? It wasn't something Dr. Alonso invented. It's the reason that that's the number that you can do accurate, not only accurate, but have an effect on terms of contact tracing. That's done specifically by the health department. All those questions are confidential. We do not ask you anything about we don't ask you for your social security number or your Medicare number. Those are scams. Please be aware of those. People are offering you free devices and things if you give them your Medicare card. Do not do that. That's a scam. That is why that 5% is so important. If you get down below 2%, down to 1%, then you've controlled, you have the virus in check in that community. And there are those are called green spots across the nation. And there are some communities that are down to that 1%. That's where we want to get to. That brings up a second problem. Every time I make a statement, I bring you another problem. That we've had some people that have been infected more than once. So now that puts another wrinkle into the equation, and why I say this virus is not normal. It's acting different than other viruses. So we have had actual documentation of people that were tested by PCR positive. They later had a negative test, so they recuperated. They went back to work, and several months later, now they got symptomatic again, got tested, and Lord behold, they're positive again.
What is the accepted general thinking about immunity for SARS-CoV-2?
Well, the reason we do the flu vaccine every year is because the immunity lasts between 2 years. And so therefore you do the vaccine every year. So you always do a vaccine shorter period than what you expect to have immunity. But there's a wrinkle in this, right? Because if you can get infected twice, so if the actual disease doesn't give you immunity, how are we going to get immunity? Do we have to get it 2 times, 3 times? What about the vaccine? So the vaccines that have come out now, Pfizer and Moderna, they both have to have 2 shots. You have to get 2 shots. So, and you have to get the shot from the same manufacturer that you got it the first time. So I can't get Pfizer the first time and Moderna the second time. You have to get, if you start with Pfizer, you got to get your second shot with Pfizer. So we're going to give you an appointment for the vaccine, and we're going to give you at the same time your appointment for your next vaccine. They have claims that their vaccine is very, very effective, 95, 94%. That's unheard of. The regular flu vaccine is about 40% effective. Okay. So, and yet, we take it. I take my flu vaccine every single year. I'd rather have 40% than nothing. We're now going to look to see how long the immunity lasts. We don't know that yet. With the second vaccine, when you get the second one, you might run up a little fever and have a little cold. So we also want people to space out their employees so that we don't all end up with the cold on the same day and everybody has to close down the work for that day. So there's a lot of planning involved in what's coming up. They're also going to be giving out the vaccine in phases, with the first groups being long-term care facilities, hospitals for the hospital personnel that's taking care of patients, and then first responders, which include fire rescue and law enforcement. So those are the first ones that are going to actually have their hands and get the vaccine. The vaccine for the general population probably will not happen until after April, May, maybe even into the summer.
When you get the vaccine, are you immune immediately?
It definitely takes time for the immune system, approximately 6 weeks. And that's something everybody needs to be very aware of, especially if you're traveling. Hopefully too many people aren't traveling right now. They're not thinking about that. But anytime that you make plans, you need to get vaccinated. You need to have time for that vaccine to actually work.
The question that I get, and I'm sure my colleagues get, and certainly the mayor gets, is this: who is positive? Why won't they tell us who is positive? Where do they live? And I say to them that that's not going to happen because of people's privacy. We cannot, in fact, I don't even know. Sometimes I may know, but I'm certainly not going to share the information. Can you address that once and for all for everybody? We don't have that information, nor should we.
Absolutely. And we keep epidemiology. The reason we have the huge responsibility of doing contact tracing is because we have special permission based on our statute of being able to obtain this information from people to prevent the spread of the disease. It's a very powerful privilege that we have, and we have to guard it and keep it very secure. So we would never talk about a specific patient. We would never say that John or Joe have COVID and they live at such and such address.
Another question that we get is is this: if I'm sick, if I have symptoms, how do I notify the Department of Health? Does my doctor notify the Department of Health, or am I responsible personally to notify?
You can ask us for any assistance you need, but the first thing we're going to ask you is, have you talked to your doctor? Because your doctor knows your medical history. We can tell you exactly what you have to do in terms of the virus, where to get tested, what you should do, how many days you should stay home, and so forth. But your doctor has your own personal information that will give you additional knowledge and things to do and not do. Okay, so the responsibility to report the test belongs on the physician that orders the test, but the labs also electronically report the lab results to us, specifically for this COVID pandemic.
What would you say to us, to our town, about surveillance testing using the rapid antigen test, or surveillance testing even using PCR, though it does take time to get a PCR back?
If the test is only as good as how much virus you have, so it may be that it's too soon and you don't have enough virus for the test to detect that you're positive, okay? So the test is only good for screening. It's not going to help you stop the spread of the virus, okay? The stopping the spread is only going to be doing by the mask, the distancing, the washing your hands, and staying away from those crowds. So if your community starts having higher numbers, yes, you might want to test so you know who is sick, but we're going to have to stop how the virus is being spread. How is it being spread? The testing, yes, it will help us know who's sick and how to treat them. That's very important. But stopping the virus, stopping the spread of the virus, has to be a community effort where we all willingly and knowingly take these steps in order to stop the spread.
One thing I forgot to ask you, Dr. Alonso, is about the hospitals, how they're doing locally. What's the availability in terms of the beds in the general area and also in the ICUs? Have we seen an increase?
We definitely have been, seen an increase in the number of COVID coming into the general beds as well as to the ICU beds. Those numbers are going up, but we have a very good control. The hospitals in Palm Beach County are, for the moment, handling this quite well. We know how to treat the patients better now. We have more available tools and drugs to help do this. And so I'm very, very proud of our whole medical system here in Palm Beach County. The other states where you're hearing of the drastic measures that are occurring is very real, because everything is happening throughout the country at the same time. We don't have the resources that New York had to be able to lots of people from Florida went to work to New York to help them out. Now nobody can go anywhere because everybody's needed where they are. So it's a very, very strenuous situation for the whole country right now. And this is going to be the worst part of the pandemic, December through January.
So we're coming into a very dark period.
Yes.
And you would like to tell us, I'm sure, how do we have an opportunity to turn that back, the dark period? Do we have an opportunity, or are we just going to have to accept it?
I'm going to put it this way. We always have an opportunity to mitigate the virus, make it less than what it was going to be. And Palm Beach County has been doing that. We've been ahead of our southern counties. We've been ahead of the game in the hospitals. The public in this county has done a great job wearing their mask, maintaining the distancing, staying home. We need to knock that up a notch and take this very cautiously so that we can help to stop the spread now that is spreading so widely. We're going to have a lot of people coming into the county, very, very heavily infected with the virus, and it's going to come down here. So we have an opportunity to heed the warning and wear our mask, stay the distance, avoid the crowded spaces, and keep the virus as low as possible in Palm Beach County. We can do that together.
Dr. Kenneth Shepke is board certified in both emergency medicine and EMS. He has been practicing emergency medicine for over 25 years and serves as the state EMS medical director for the Florida Department of Health, as well as the EMS medical director for 6 fire rescue agencies in Palm Beach County, including the town of Palm Beach. Dr. Shepke is a nationally recognized expert in EMS and has been involved in the state's COVID-19 response since the beginning of the pandemic. And along with his background in emergency medicine and biochemistry, he is highly knowledgeable and informed in the development of the many vaccines on the horizon to prevent COVID-19. Here's Town Council President Maggie Zeidman and her eye-opening interview with Dr. Kenneth Shepke.
Can you tell us what are the different types of vaccines? What's messenger RNA? And how do they work on our immune system?
Sure. So the messenger RNA vaccine is the newer technology, and I don't want to say brand new because it's been around for actually 30 years, but it's really been in the last 10 or 15 years that there have been some major medical breakthroughs using messenger RNA as a vaccine. The Pfizer and Moderna vaccine candidates are both in for emergency use authorization now. We should be hearing from the FDA basically in the next week or two on whether or not they'll receive emergency use authorization. They have almost identical technology, in that these are not viruses. Typically in the past, vaccines were made out of viruses, but this is not a virus at all. This is a man-made lipid nanoparticle. And basically that's fancy words for it. This is a little tiny ball of fat. And into this little tiny ball of fat, they put this molecule we call messenger RNA. And what messenger RNA is, it's basically a strip of genetic material that encodes for a protein. Our body makes antibodies to proteins. So whatever messenger RNA you put in there, that goes into that little lipid nanoparticle. They inject you with that, and that gets into the body cells. And then once the messenger RNA is inside the body cells, the cell's machinery takes that messenger RNA and reads that as a recipe and creates a protein. And that's important because your body's immune system can recognize proteins that don't belong. And so we use that messenger RNA to encode for the spike protein in this case. So when your cells start making the spike protein at the site where you were injected, your body's immune system say, hey, that doesn't belong here. And they start creating antibodies and T cell immune response to that spike protein. And that's how we can develop immunity to the COVID-19 virus without ever being injected with the virus. So AstraZeneca and Johnson & Johnson are the next two that are up. They use a little older technology where they actually use a virus, something we call an attenuated virus. In this case, it's in the AstraZeneca product, it's a adenovirus that causes a cold in chimpanzees. And they modified the virus genetically so that it cannot copy itself. And then they added the genetic material that encodes for the spike protein. So again, we're targeting the spike protein. And then when you get injected with this vaccine, that weakened virus attaches to your cell, injects that genetic material into the cell, and then again, the cell's systems take over and converts those genetic messages into the spike protein. So we did see some news from AstraZeneca. They published some early results. It's also effective, not as effective as the messenger RNA vaccines. Both of the two messenger RNA vaccines we found had a 95%, 94% in Moderna and 95% efficacy in the Pfizer product. Johnson & Johnson is also an adenovirus vaccine. That's also in the pipeline. We expect that early 2021, those two companies will apply for emergency use authorization. And then the last one for the United States, at least, I mean, there's lots around the country being developed, but in the US, we've got 5 of them. The last one is the Novavax candidate. And that one's not a virus either. That one's just a piece of the virus. In this case, it's purified spike protein. Purified spike protein is going to have to be combined with something else that stimulates the immune system, something we call an adjuvant, because the protein alone doesn't usually stimulate a really robust immune response. So that one will be combined with the adjuvant. And so far, early results from that look good, but they're not quite as far along as the other. So that won't be until later into 2021 that we see those guys apply for emergency use authorization.
I think, Dr. Shepke, if it's okay with you, we better start with a primer if we're going to talk about vaccines on the ACE2 receptors. So take it away. Tell us about that.
So when a virus infects our body, it needs to be able to attach to our cell somewhere. And the ACE2 receptor is where the virus that causes the COVID-19 disease attaches. The ACE2 receptor has certain functions in our body that unrelated to this infection. And the virus just basically developed in order to exploit that ability to attach that particular protein that exists in our cells. Now, this particular receptor exists on lots of mammal cells, which is why you can see this particular disease cross species. The protein of the virus that attaches to our cell at the ACE2 receptor is called the spike protein of the coronavirus. And that is where we want to target our immune reactions, because if we can attack those spike proteins, then we can basically cover up all of those attachment points so that the virus basically becomes inert and is unable to attach to our cells. That's one of the focuses when you look at all the various vaccines, is to attack that spike protein that attaches to our ACE2 receptors.
Are those ACE2 receptors found all over the body?
That's a great question, because the location of those receptors kind of gives you a clue as to what kind of symptoms you can get. So certainly they are in the respiratory tract, which is why you get a lot of respiratory symptoms with this. But they're also found in lots of other organs, such as the gut, which is why you see a lot of GI symptoms like vomiting, diarrhea with this, abdominal pain. They're in the kidneys. They're in the heart, which is why this can actually cause something we call myocarditis and even heart attacks. And very importantly, they are in the blood vessels. And that was something that we learned early on in this disease, that this was not acting like a normal respiratory disease. It seemed to be much, much more than that. And that's because this thing causes all those different organs to be infected, and especially the blood vessels. And when that gets infected, it causes these blood clots. And so we were seeing this as a really big problem and a big issue that we needed to deal with, was blood clotting all over the body, in the heart causing heart attacks, in the brain causing strokes, and in the lung, basically thousands and thousands of tiny blood clots in the small blood vessels of the lung, causing a drop in our oxygen levels in patients that are infected with this.
Is there anyone that shouldn't get the vaccine?
So we still have as you can tell, just watching the news, this is a rapidly changing topic, and we're still learning a lot. So there are definitely still some unknowns when it comes to this. Folks that have autoimmune diseases and immunosuppressed from other reasons typically have to be a little bit cautious about vaccines, particularly getting vaccines that have live viruses in them. Because while a weakened live virus doesn't normally infect, it's not usually strong enough to infect somebody within a normal immune system. If you have a weak immune system, it could potentially or theoretically cause a disease in you. The nice thing about the messenger RNA vaccines is that they are not viruses at all. They can't infect anybody. They can do one and only one thing, which is encode for the spike protein, and then that's it.
So what if not everyone gets the vaccine? What happens about herd immunity then?
Yeah, so we don't need everybody to take it. So you're absolutely right. That's the concept called herd immunity. Now, you can get herd immunity by allowing everybody to get infected naturally, and that's not a great way of doing it because a lot of folks will have long-term illness or organ damage or even death from this. Or you can get herd immunity by vaccinating a certain percentage of the population, and it varies. The percentage of population that needs to be immune varies by the infectiousness of the particular disease. In this case, COVID's fairly contagious. So experts are estimating that we need 60 to 70% of the population to be immune to kind of get this to stop transmitting.
Period of time was shortened to get us to where we are with these vaccines. And some people are afraid that maybe not everything was done that should be done. Could you address that for us?
People think because we got here so quickly that there must have been some corners cut. And that's not the case, actually. It's especially in the case of these messenger RNAs. And the exciting thing, it's hard to say this exciting with such a terrible pandemic, but we've really seen major medical breakthroughs with these messenger RNA vaccines. We will forever be able to make vaccines quickly now because of this new technology. Moderna and Pfizer have a 94 and 95% efficacy rate, respectively. That's grand slam efficacy level. I mean, if you just look at some of the best vaccines we've had in human histories, like measles, that's upper 90%. A typical vaccine, like the influenza shot we get each year, averages only 40%. That's 40% efficacy rate. So to have something that is this highly efficacious, that's absolutely fantastic. It's much better than we were even our wildest hopes would be for this vaccine. So it looks great for the future for us.
Are there any side effects to the vaccines that you know of?
There are, and that's so. Again, to the Moderna and Pfizer, I'll talk about them because they're coming out first. The side effects were relatively mild and generally occurred after the second shot. Both of these are 2-shot series. I mean, you'll get the first shot today, and then you get another shot 3 or 4 weeks later. And it's with the second shot that you typically see some typical stuff that you get with lots of vaccines. You might be a little achy, you might have a low-grade fever, might get a mild headache, things like that. Generally, they were mild, self-limited. Got better with Tylenol, lasted 1 to 2 days. So relatively minor and common with lots of other vaccines.
Now, with the Pfizer vaccine, and to some extent Moderna too, the special handling is required, freezing basically. So with something like that, how do you see that being rolled out to the general population? How will that be distributed?
Well, the Pfizer especially has to be stored at negative 80 degrees centigrade. So this is not your normal kitchen freezer that we need. Now that's for long-term storage. You can actually put it in a regular refrigerator, but that only lasts for 5 days. And the last thing we want to do after we've been waiting this long for a vaccine is let a vaccine expire. So we are going to, and we already have positioned these special freezers around the state where we can store the vaccine, and then we'll do secondary distribution to the folks that are going to be giving the shots in the arm, so to speak. Moderna will probably be a little easier because while that does need to be frozen, it doesn't need to be frozen to as cold a temperature. And you probably use just a regular freezer for that. And then that really opens up a lot of distribution sites for it. So I see this as a well-coordinated storage area where there's going to be depots around the state with the folks that have these various cold, ultra cold freezers, and then with secondary distribution to the points of where we'll be using it.
Would you consider, I think I saw this in one of the great films that you've done to educate people and educate EMS, the paramedics, using the testing sites as actual vaccine distribution sites?
Absolutely. So one of the, and there'll be multiple models for mass vaccination, but one of them, just like we're doing mass testing where folks drive up and we do a swab of their throat or the nose, well, we'll just swap out we'll change out the swab for a shot in the arm. So the same mechanism, you drive up, we'll do some clerical stuff to get your name into the database so we can track you, let you know when you need to get your second shot of the vaccine. And then we just give you the shot in the arm.
We're going to head over to the more local level now to see what Chief Donato has in store for this community itself.
And Dr. Shepke, and you spoke earlier about the mass testing sites. And, and so while everybody needs to get vaccinated, we're hoping to take some of the burden off of those mass testing sites by providing very localized vaccinations here in our community in settings that people are comfortable with and familiar with here in our community. And we do that through what's called a closed pod. We've trained all of our paramedics on the requirements for vaccinating folks. And then we've got agreements and MOUs in place with the county health department. And we've got the go-ahead from the state. We registered in the Florida SHOT system to be a vaccine provider. All that was put in place, and we're ready to go. We've seen a large uptick in the number of cases in our community. That's to be expected somewhat with more people coming back to town, but we can do something to reduce it. As individuals, we can make a difference. And I just ask for the next couple of months, you do your part, protect yourself, protect your family, protect your friends, and protect those in the community.
Thank you, Chief. That's the message. And thank you both. Thank you, Dr. Shepke. Thank you, Chief Donato.
Dr. David Dodson has practiced internal medicine and infectious disease in West Palm Beach since 1985. He is a graduate of Cornell and Cornell University Medical College. He completed his infectious disease fellowship at Yale New Haven Hospital, where he also worked at the Yale Tropical Medicine Clinic. Dr. Dodson is double board certified in internal medicine and infectious disease and is a fellow of the American College of Physicians. Here's Maggie Zeidman and her interview with infectious disease expert Dr. Dodson.
People just don't understand that they look healthy, they feel healthy, the person next to them looks healthy to them, and they think they are healthy, but they may not be healthy. Can you comment on that?
One of the frustrating things about this whole epidemic is we've known since basically March how it's transmitted. We've tweaked a couple things, but basically it's transmitted through respiratory droplets, maybe aerosols, through close contact, and some is transmitted through things that we touch and then touch our mouths. So it's frustrating because this entire pandemic is determined by our human behavior. And that our behavior has not been good to allow the virus to spread this quickly. The latest numbers out of Florida are 7 to 8% positivity, both in the state and in Palm Beach County. So you're walking around and chances are, 8% of the people that you come into contact with are infected. And if you're in contact with them, then you get infected. So we watch the viral load numbers, and then we watch the people get together. And in Florida, we're stymied by the fact that our political leaders have made a vow to keep all the bars and restaurants and everything open. And that's exactly how this virus is spreading. So unless we do something different, the numbers are just going to keep going up.
When is a person most infectious?
So when you get infected with the virus, it takes a little while for the viral load to start going up and then you being infectious. So if you develop symptoms, you're infectious about 2 days before you develop your symptoms, and then for about 7 days afterward. So there's about a 10 day window of infectiousness when you have the virus. So, and it seems to be that after 10 to 14 days, that's where the quarantine period comes. After that, you've probably overcome the virus and are no longer infectious. Although sometimes after 14 days, if you do a PCR test, sometimes you can still detect the virus, but it's probably not viable and infectious.
How can we get it? Can I get it if I walk through air that someone else who is infected has just been, say, on the lake trail?
So based on the size of the virus, it looked early on like the only transmission would be through respiratory droplets, and those travel about 6 feet. So that's where the 6 feet came from. But subsequently, they found that sometimes the virus can get trapped on little particles and actually stay in the air for a longer period of time, like an aerosol would. So that's where that part came from. But classically, it's a respiratory droplet transmission, not an aerosol. But we now know that there may be some particles that are in the air, and particularly if you're in an enclosed space, like a restaurant or a car, sometimes those viral particles could circulate in the air and infect others. So that's why it's important that if you are with other people, that it's in an open area, like not an enclosed restaurant, but a place with good ventilation. We've learned that ventilation is a key factor that contributes to transmission.
There's a lot of confusion about testing, and it can be challenging between the PCR test, the rapid antigen test.
So when you get infected, you have some viral particles. And, if you get a large inoculum, like if you're a healthcare worker and you get a lot of viral particles, you could actually be tested with a PCR the next day and possibly be positive. For most people, it takes a few days for that viral load to go up. And kind of the optimal testing time is around 5 days after whatever exposure it was. That's your best chance of getting a PCR. So, and the PCR is the most sensitive test that we have. So generally a PCR can detect virus at 4 or 5 days, whereas the antigen tests generally can detect virus at about 7 days or so. And they also have some false positives. So the PCR is a gold standard. You can pick up the virus at 4 or 5 days into the infection. And that's really the most reliable. The antigen tests, they are quicker. Some of them are like 15 minutes. They're cheaper, but there's about a 10 to 20% false negativity rate of the rapid antigen tests. The White House found that out. They were relying on these rapid tests and not using the masks and everything. And so they turned into a super spreader place, a hot zone. When you get tested with a PCR test, that is at that point in time. So you're either infected or not infected at that point in time. But if you do the same behaviors that brought you to that point, that is, you maintain your distance, then it's unlikely to get infected. But it's true. If you had a negative test on a Friday night, and then on Saturday night you went out to a bar with your friends, you could be positive the next day. That's true.
Let's just jump to vaccine just for a moment, because the two vaccines, will you go ahead, you tell us about those two vaccines, please, Dr. Dotson.
Well, first of all, to have had vaccines developed in a matter of months is a remarkable historic achievement. This is the first time in humankind where we've faced an infection like this and come up with a vaccine in this short a time. We spent $24 billion developing a vaccine, but that then my mind goes to why didn't we use a low-tech solution like masks? Why do we have to spend money on vaccines when we could have prevented a lot of these infections by just changing our behavior? But that's a question for another time. So the early information that we have on these vaccines is from the companies. That what they did, like the Moderna vaccine, that they counted 196 cases. They gave the Moderna vaccine to a lot of people, to thousands of people, and then 196 people developed a COVID infection. And then they unmasked those people, and they found that 185 of them were placebo, and 11 of them were people who'd received the vaccine. So that's where they came up with this 95% effective thing, and the same thing for the Pfizer vaccine. So we've seen the questions we have are, it seems like the vaccine can prevent disease, but what we don't know, and the studies weren't designed to find this out, is whether they can prevent asymptomatic transmission. It's possible that the vaccine may prevent you from getting real sick, but may not totally eliminate the virus, and you still could be potentially infectious. So that's one of the questions that we'll have to find out. So, going back to antibodies, normally when you get over an infection, you develop antibodies to prevent a second infection. What we don't know about the coronavirus is how long these antibodies last, or how strong the immunity is going to be. And the purpose of a vaccine is similarly to induce your body to make antibodies. So that, again, that's the question is, one question became, should we be giving vaccine to people who had already recovered from COVID and had antibodies already? So the answer seems to be, for most virologists, is that we don't know the protection that we have from antibodies from natural infection. So go ahead and give the vaccine to everybody. It may end up boosting the immune response in people who've had it. And it certainly will do that in people who have not been exposed to the virus.
Doctors have learned so much in the last 9 months. Can you tell us some of the things that are being used now and what has changed from the beginning?
Yeah, so the mortality of COVID infections is going down. It may be because some of the treatments are better. It may be because more younger people are getting it, and that may skew the mortality down. And also, people are wearing masks. And the thing about masks is it may not give you 100% protection personally against other people, but there's something called the inoculum, which is the amount of viral particles that you are exposed to. And if somebody with COVID were to cough nearby, if you don't wear a mask, you'll get a lot of viral particles. If you do wear a mask, you'll get a lesser number of viral particles. And the less the inoculum, probably the better off you're going to be. So the masks do protect you to some extent, although they're much better if you have COVID in protecting others from disseminating your own viral particles. So there's 3 basic treatments, and we'll go through them sequentially, and we'll use the president as an example. So when somebody is infected, the very first thing you want to do is to stop the virus from infecting other cells. So we have 2 monoclonal antibodies that have just been approved, the Regeneron product and then an Eli Lilly product. So once these are more available, the best time to use the monoclonal antibodies is right after you get the positive COVID test. Because what the monoclonal antibodies do is they grab onto the virus and they glom onto the receptors so the virus can't infect human cells. Mm-hmm. So that's the best use of that. Now, once the viral infection gets going, then we want to stop the replication of the virus. So that's where remdesivir comes in, because remdesivir inhibits viral replication. It's not a game changer. It'll decrease the amount of days in the hospital. It's not a dramatic cure, but it helps. So we use remdesivir typically a little ways into the infection. And then if you require oxygen, either nasal oxygen or if you end up on a ventilator, it's been found that dexamethasone, a steroid, will decrease your mortality. So it's a 10-day course of dexamethasone. But it does no benefit. There's no benefit whatsoever if you don't require oxygen. So if you're an outpatient or you have mild disease, it's not recommended. So it's only if you're getting bad enough where you need the oxygen supplementation.
What's your advice for Christmas? Travel? Don't travel?
Well, right now we're kind of into the 3rd peak. We've never really turned off the infection. We've just had higher peaks, and we're into the 3rd peak now. And the advice for Christmas is the same as the advice for Thanksgiving. Don't travel. Don't get your families together. I mean, if you want another Christmas next year, then stay alive for this Christmas. So limit the gatherings, limit the travel, because we have to stay alive. There's some light at the end of the tunnel. We'll have vaccines next year, but we have to get through this winter.
You've seen people on ventilators, and you've treated a number of them in the intensive care unit. who have COVID-19 pneumonia and all kinds of other illnesses that the virus has caused. It is not a pretty sight. It's very difficult on the person. So can you say something that would help people to understand that it's not a place that you want to go. It's not a place where you want to be. It's a challenge to the doctors, to the nurses, but it's mostly horrible for you and for your family.
Yeah, so what we've learned as the COVID epidemic have evolved, initially, the people who died were elderly with multiple comorbid conditions. But as more and more and more people have gotten infected, we've seen young, healthy people develop severe COVID infection, pneumonia, and die. It's more common in people who are older and have other conditions, but we've seen children die of this, we've seen young adults die of this. So the best thing to do is not get infected in the first place. And because that's where your COVID journey starts. And once you're infected, then, there's a finite number of things that'll happen. You may be asymptomatic and be fine. You may develop symptoms, and most 80% of people will have a viral syndrome and then they'll get over it. But a lesser percent will end up in the hospital, and a lesser percent of that will end up in the ICU with COVID pneumonia. And the sad thing is that because of all the isolation, all the isolation that has to go on in the hospital, family members can't be with their families, their members when they're dying. And so there's so many people that are dying lonely. Their last word is to their family is through an iPhone or an iPad, and that's just horrible. And when you're on the other end of it, you're suffocating slowly, and it's very difficult. It's a very frightening journey to be on. So the best thing to do is not to get this infection.
We encourage you to recommend this program to others on the island or friends wherever they are. And we urge you as well to wear masks. It is considered a social responsibility in our town. It is selfish not to wear one. And as we enter the Christmas, Hanukkah season into January, it is of the utmost importance. We appreciate you watching, and we'll talk to you soon.